Fantastic. So welcome everyone. We are now back for week 7 already of joint school. And with me today I have Professor Tim Board to do a special session on hip replacements, but particularly for those who are a bit younger than what may be considered the norm, or what certainly is the typical average for people having hip replacement surgery. And thank you so much for everyone who's sent in questions and suggestions for topics to cover around this. I know it's been something that we've had quite a few suggestions and comments about, so thank you very much for that. But before we dive in, also, as ever, very important to highlight that while Professor Board has a wealth of experience for us to share with us and for us to dive into, of course, as ever, nothing we discuss here is personalized medical advice, and all we can really do is touch on the general trends and the general information, but we hope that you will find the information helpful nonetheless, and perhaps a few points that you can take with you and help to answer some of the things, in particular that we've sent in. So, Professor Board, thank you so much for joining us.
You're welcome. Nice to talk to you, Axel.
Yeah.
Long time no see.
Yeah, it has been a little while, although not too long.
Yeah.
And it's been great, really, seeing seeing this joint school app project pick up, and these videos and the questions coming in, and we've had some really great responses, in particular from people who are a bit younger than what the stereotype might be for people having hip replacement surgery. And that is indeed a field that is very, this is something that you specialize in, really.
Yeah, that's right. So I work at Wrightington Hospital up north of Manchester. It's a specialist orthopaedic hospital. So all we do there is orthopaedics. And a lot of that is joint replacement. So a lot of low limb joint replacements, and a lot of hip replacements. In fact, I think we do probably more hip replacements than almost any other hospital in the UK. And I've worked there now for about 12 years as a consultant, and through that time, it's funny how your practice just sort of tends to evolve towards a sort of degree of subspecialization. And I seem to have been sort of sent younger and younger patients over the years, and kind of developed somewhat of an interest in hip replacement in a younger person.
And how was that? Was that sort of a gradual evolution, or was it something that you sought out, or did it sort of find you?
Well, I think it's partly a gradual evolution and a number of sort of random events, I suppose. I also do hip arthroscopy for patients with impingements, and obviously that's in the sort of the younger age group. Mm-hmm. And many of those patients, when they're referred in, they've had problems for a long time. They're young. Maybe their GP's not X-rayed them because they thought, well, this patient's only 20 or 30 or whatever, and has hip pain, and it's not going to be arthritis at that age, so I'll just treat them conservatively. Mm-hmm. And then they eventually get referred in, and maybe an X-ray at that point does actually show that yes, they had impingement, but it's kind of too late now, and actually now they developed arthritis. So, and then in many of those cases, the only solution would be hip replacement. So, by having an interest in impingement, you also then end up seeing a lot of young patients with arthritis. And then because you do both operations, you obviously treat people with whatever the appropriate intervention is for that person. Yeah. And then as you do more younger people, you sort of get referred more young patients as well. And also, a really interesting part of my practice now is actually pediatric hip replacement. So I was actually at university with a friend of mine who is a pediatric orthopedic surgeon. Mm-hmm. And a few years ago, she referred me a young girl who she thought needed hip replacements, but and she had a systemic disease, not just sort of straightforward arthritis, obviously. Mm-hmm. So we actually went across to the kids' hospital and did double hip replacements on her. In a staged way, and that was incredibly successful. And since then, we as a team, myself and the paediatric orthopods at Royal Manchester Children's Hospital, have done a fair few paediatric hip replacements, and they've really been transformative in terms of life improvement for those kids, getting them out of wheelchairs and things like that. So that's sort of the extreme end of the spectum, and not really the bulk of what we'll be talking about today. No. But it kind of fits into that. How old do you have to be to have a hip replacement, or conversely, you're too young for a hip replacement question. That's a question we get asked all the time. Am I too young for a hip replacement? And I always say to patients, it's not about age, it's about quality of life. A hip replacement it's not a saving life operation, but it's a quality of life operation. And it's incredibly successful at improving people's quality of life if their quality of life is impeded by their hip problem. And if they've got a severe hip problem with it, arthritis or some other issue destroying the hip, and their life is really restricted because of that, a hip replacement has a very good chance of improving that quality of life. And in a young patient, they might say, well, it's not, I was told it's not going to last the rest of my life. It'll only last me, X number of years, whatever they've been told, 10, 15, 20, 25 years. And therefore they shouldn't have it because they need to wait until they're 60. But every single patient I've had a conversation with along those lines, they've all said, yeah, but I want the quality of life now. I don't want to live for another 10, 15 years in this degree of pain and limitation. I can't go to work, and relationships are affected, and I'm depressed and angry, and all these knock-on effects of living with pain. And I say, well, if I can get that many years, then I'll deal with the revision if and when it's required. And I think that's an absolutely reasonable way to consider it. Doing a hip replacement in a young person is not it's a lifetime commitment, because once you put a hip in, you can't go back and have your old hip back. So once you've got an artificial joint in, you are always going to have an artificial joint in. But it's really important for younger patients to understand that it may well be that they need to have a redo operation, as we call a revision. And generally revisions don't last as long as the first one. So you get on a little bit of it lasted this long, and now it's this long, and now it's that long. So that you do have to be very cautious, obviously. And the patients, really do need to understand, and they do understand that, it might well be that things might quickly deteriorate in the future. For example, if they had a revision and then there was a complication, it might not last as long, and then these things can sometimes snowball. But this all comes out in the consultation and the consent process about talking about these issues.
Yeah, absolutely. And I think from the questions we've been sent in now, and from generally through the myrecovery app and so on, I think it seems that for younger people who are either considering or have been booked in or are getting ready for having a hip replacement surgery, I guess as for everyone, it's a very it's a personal decision that each individual makes together with their surgeon, a shared decision about treatment. But I guess within that, there are sometimes challenges for the individual, because it is about quality of life, and you compare with someone else. And I think so some of the questions are around, like, well, should I hold out for a bit longer? We had a couple of questions that have been sent in from people like, well, could I benefit from waiting 6 months, a year, maybe even 2 years of putting up with more pain to before I have the hip replacement, to wait for any incoming new innovations that might help, or to be able to extend how long this new hip will be within me and will help me. And so I guess it's quite a difficult balance.
Yeah, so I think there's a few things in there. I think one of the first things that often people say is, I've got this pain and it's stopping me doing these particular activities, be it I can't walk my dog anymore, but I can go to work, and everything else is kind of okay. Or maybe it stopped me playing golf, and I'm not a golfer, but some people, that's their life, and if they can't play golf or whatever their chosen sort of hobby is, fell walking, or whatever, then that, some people might look at that and say, well, you're fine because you can still go to work and you sleep all right-ish at night, and why are you worrying about that? But actually, for those people, that's a massive impact on their quality of life. And I think that's when it becomes really an individualized discussion and a question. And people really shouldn't be, frightened of saying, this is how it's affecting me, and how important these particular things may or may not be to an individual. You'll find the other thing I think was important is you'll find a massive variation in surgeons' attitudes towards what's appropriate for a joint replacement.
Mm-hmm.
The classic, sort of statement that if you get 100 surgeons in a room and ask them a question, you'll get 100 answers.
Or more.
Or more. Yeah.
Yeah.
Yeah. So you do get difference of opinion. So I think that's an important factor. I think the question about should I wait a bit longer? I think that's a really interesting one as well, and obviously people often ask that. My view on that, and as I said, it's everybody's has different views, but my view on that is that if you're, let's say for example, if you're 30 and you've got a really bad hip and you're struggling, and the advice may be, or you might consider, well, what if I could wait another 5 years? Well, 5 years is a long time. Particularly, at that age, that's like, massive change in what you might achieve in your career or family or whatever. And to wait 5 years in pain is a long time. And then if you say, well, what's that achieving in terms of the life of a hip replacement? So life expectancy is roughly sort of 85. So for a 30-year-old, you're looking at 55 years of life for a joint replacement in that person. Obviously, it's unlikely that a hip is going to last 55 years. And even if you wait 5 years, that's 50 years. That's not that different. So in terms of the sort of lifespan into the future, waiting a few years when you're young doesn't make a big difference to how long that hip has to last for. It is a long time to wait in pain.
I think that's a very I think that's a very wise response to that question. I think, we've been getting ahead of ourselves a little bit, because I had a sort of a bit of an idea of moving through it chronologically, and I just want to make sure that we do cover some of the key questions that have been sent in, because there's been some really good ones, and I think just to sort of set some markers, really. Like you've mentioned that you also do pediatric hip replacements. And sort of the lower extreme, if you will, of in terms of the age range. But a couple of people have asked, like, what is the full maximum age range? What is the youngest one could conceivably have a hip replacement? And I guess what's the oldest? So this is a bit beyond the scope of this conversation, but just let's have the full spectrum.
I mean, so I mean, for my practice, the youngest patient I did was 10. Obviously that was a unusual, very, very unusual sort of situation. But again, it demonstrates the fact that if it really is required, then it can be an appropriate thing to do. But that's very, very unusual. It's teenagers, that happens. I'd say infrequently, but definitely happening. 20s, I've treated loads of 20-year-olds, and sort of as you go up by decade, it gets more and more frequent. Really, really common to people in their 40s having the hips all the time. Obviously the average age, the National Joint Registry records data on all hip replacements. The average age, I think, is about 68. That's the average age for a person having a hip replacement. But obviously half the people are younger than that. And half are older than that. So it stretches all, right down from that really young age. And clearly there are well documented people, members of the royal family, that have had it replaced in a very old, old number of years. And people in their 100 have had hip replacements. It's all, when you get to that sort of stage, it's all about, not really about sort of the chronological age of the patient, but what we call the biological age. So, one person who's 90 may be very, very different in their fitness and their ability to withstand surgery than another patient who's 90. So it doesn't really come down to age as much at that end of the spectrum, more of how fit is this person, and is it the individualized discussion about how it's affecting them, their quality of life, etc. It might be at that age that they're on the brink, a person who's living maybe on their own or with a family member, who is on the brink of not being able to be independent anymore because they can't walk and they can't get out of bed on their own because of a really stiff joint or something like that.
Yeah, yeah.
And then a hip replacement or a knee replacement, whatever, may be the thing that actually enables them to preserve their independence for a number of years. And that could be a really, really valuable thing to do.
Yeah, interesting. And so with the average being around 68, and as you say, that means half are younger and half are older. So if we move back from about 68, 70, and into younger ages, sort of decade on decade, what are the considerations that are different, say, if you for someone in their 20s having a hip replacement, or what are the special considerations for someone in their 30s?
I think it boils down to a lot of things. Obviously, the younger the person is, the more likely they're going to have something which isn't sort of common or garden arthritis. So they might have had a childhood hip disease. They might have had maybe an infection when they were a child or something like that, or Perthes disease, which has led to or avascular necrosis, which has led to a collapse of the hip somehow. And so the anatomy of the hip joint in a young person may well determine, how you approach that from an implant perspective, and those kind of things. So if there's really abnormal anatomy, that's going to govern how you might do that operation in terms of the choice of the socket and the choice of the stem, and those kind of issues. But if it's, if it's a straight, just an arthritis, and the anatomy and things are relatively normal, then really any sort of run-of-the-mill type of hip replacement, any, probably the wrong word, run-of-the-mill, but any of the commonly used hip replacements,
and well validated, and
absolutely, yeah. So sort of gold standard, maybe.
That's the term.
Yeah. Could be used in those patients, no matter what their age.
Yeah.
And again, that's kind of what you actually use boils down to the sort of the surgeon's preference and the patient's beliefs and wishes, etc. But you will find that the types of implants that are used are different in different hospitals, different parts of the world. Big variation across the Atlantic, particularly, and where people have been trained and the units that they work in.
And actually, that's one question that popped up more recently yesterday on one of the groups. So there was a conversation about implants and how they do differ in different parts of the world, and yet does that translate into any difference in significant difference in outcomes by and large?
Not specifically, not in a big way. No. I mean, there may be small differences, but as you know, in science and medicine, to really see a difference, you kind of need to do a randomized controlled trial where you govern all of the other variables. And you might say, well, there's a bigger risk of a particular complication in America, say, compared to here, for example, that there might be. But then there are lots of other factors. The BMIs are high, and the numbers of operations that surgeons do governs the success as well. So there are lots of factors.
And as we're sort of circling around implants, I think I'll do the two sort of implant related questions that were sent in now as well. So there was one was asking sort of the difference between a mini hip implant that they've come across and a sort of normal sized hip implant, and when one would be better than the other, and why. When would a mini hip implant be used for good reason, and why instead of sort of standard size?
Yeah, so mini hip implants. I think the mini hip does refer to a specific implant, but there are kind of smaller hip replacements of many different designs, and they get kind of lumped as a mini hip or whatever. And the purpose of those really is that so that it's all about the stem, the femoral stem, the bit that goes down inside the femur. And they're generally shorter, so they don't reach down as far in the bone. And the purpose behind that is that then if it requires revision in the future, then effectively you've got more untouched bone, more healthy bone to deal with. And it might be that if you were to revise it, you could put a sort of a standard length primary hip replacement in place. So it's kind of to a certain extent, it's about trying to protect bone for the future, trying to be as sort of conservative as possible, which is a fantastic aim to have. But as with all these things, there's no such thing as a free lunch. And when you use, except when we come to your offices, obviously, Axel, but when you use something which is maybe newer, a shorter stem, a mini hip, the track record of that implant is not as well known as maybe a more gold standard implant. So by putting an implant in like that, you're doing it to try and achieve something for the future, but you might then be exposing the patient to a slightly higher risk of something else in the sort of immediate time. So it's difficult to balance those risks against each other. So overall, the reason is to be more conservative with bone, because redoing operations and revisions and another revision, whether you can do that or not depends largely on the bone that's available. So preserving bone is really important.
And of course, as we've highlighted, the real decision around that is, and the real balance is something that has to be done on a case-by-case basis with each individual, between
absolutely
you as a patient and your surgeon. But that then brings us on to the next sort of implant question, which is, of course, the Andy Murray question. And so as many people will know, and Andy Murray not too long ago had a hip resurfacing, which is sort of a different variation. And I guess is a sort of, in a sense, the next step on from what we've just discussed. And I think, there's a few people I've come across who are like, well, I'm pretty much a similar age. I'm not an elite tennis player, but I'm quite active, and I would like to be able to enjoy sports and these things, and yet I'm being recommended a total hip replacement, not a resurfacing, and I guess that can cause some questions and some uncertainties, which are quite understandable. So.
Yeah, absolutely. So I mean, hip resurfacing was really, really popular quite some time ago, but more than 10 years ago, and it really took off, and it was a considerable number of hip joint replacements in the UK were resurfacings. And undoubtedly, many of those patients achieved really, really good function. There were not really any really well-designed randomized controlled trials that proved without doubt that you got better function with a resurfacing compared with a hip replacement. So all the studies were kind of what we call cohort studies. So you take a group of people that had a resurfacing, and then you looked at how active they were and said, well, they're better than that other group that had a hip replacement. But then obviously those people have sort of sought out a resurfacing and have had it because they were active. So there's sort of this self-selection issues. But nevertheless, patients did generally do really, really well with these things, as they do with all hip replacements. So it became very popular. But then there started to become a lot of problems developing around the muscles and soft tissues in some of these patients. And that was due to the metal that's released from the hip replacement. So because it's a metal ball which goes on the head and then a metal shell, the two rubbing together, it's a metal on metal bearing surface. And in an ideal situation, it works perfectly well because you get a bit of fluid in between and the two don't actually touch when they move, a bit like a water ski, it lifts itself up. But in many situations, you don't get that fluid, and actually you do get rubbing of metal, and that releases metal into the body. And it became apparent that quite a large number of people had started to develop really quite severe reactions around the hip. That got many different terms were used at that time: ALVAL, ARMD, pseudotumors. And all these things are essentially a spectrum of basically soft tissue damage because of the metal released. And it does get into the bloodstream, and many people have had blood tests looking for cobalt and chrome ions in the blood. And whilst we do now understand a lot of what causes this kind of problem and how you can mitigate against that risk, we don't fully understand everything about it. So the number of resurfacings massively dropped off. So the vast majority of people just stopped doing it because of these terrible problems that led to lots of revisions. And so there's very, very few people that do resurfacings currently. I personally don't. I did do resurfacings back in the day, but I don't now. And when people ask me why, when patients ask me and ask about it, I say that I don't feel we understand the biology of the problem. So, if you put a hip into someone, a resurfacing, you do it perfectly, and it's a great design hip, you can still get these problems. And that's because there's something about the way an individual might react to that. Right. Not necessarily it's a hypersensitivity or an allergy, but there's something around the way the immune system reacts to that and the cells react to it. So I wouldn't have one. And I think that's, as a medic, as a surgeon, putting in implants, I always think back to, I have to put into patients what I would be happy to have myself. And I wouldn't have one in me because I'd be worried that I might develop a problem, even though I would, I'd really obviously want to get as maximum function as possible because I like running and cycling.
Yeah, you're very active as well.
So I think it's still a little bit of an unknown around resurfacing. There's no doubt that if you have good designs, they work better. If they're put in well by a good surgeon, they do better. So yeah.
And again, it comes back to that conversation that people will be having with their surgeon and working out, your individual anatomy and what quality of life means to you, and then your surgeon and their experience.
Yeah.
And we spoke a bit about the timing of having the hip replacement operation, and of course, we are having a Zoom call now, and the Joint School app and the whole project is all a response to the COVID-19 pandemic, which has meant that there's many people out there who had planned procedures that have been postponed or perhaps even cancelled with for the moment, and people are facing a lot of uncertainty around this and delays of at least a couple of months and perhaps even more. Now, so of course that is a concern for many, and we've had a lot of questions around, what sort of things could I be doing to make the most of this time before a hip replacement surgery? And I guess related to that, there are a few more slightly specific questions that are sort of, it's a bit difficult to give a specific answer to, but it's for sort of some people who have been waiting for bilateral hip replacements, for instance, where they have had one good hip and they're sort of they've been relying on the operation being done on the bad side first, so to speak, and then having a good hip to rely on. But they're feeling that now if I'm going to have to wait much longer, then I won't have that good hip to rely on anymore, and they'll both be quite bad. And how does that impact recovery, and what things can be done to try to resist those processes and again make the most of a difficult situation?
Yeah. So it's a really hard situation for people to be in. I think often patients find when they come for consultation originally, and we decide that they're happy to go on a list, even though that putting someone on a list doesn't make any difference to their pain, it makes a difference to their ability to cope, because it's a light at the end of the tunnel. Yeah. And then if you have a light at the end of the tunnel of a bad period, you can kind of cope a lot better. And then to have that light sort of switched off and say, well, we don't know when it's going to happen, is psychologically very, very difficult for patients to deal with. So yeah, it's a really hard position for all these patients to be in. I think in terms of trying to help things, we know that arthritic joints, need to be exercised. The muscles around a joint, generally become weaker. The body will try and protect a painful joint by offloading the muscles, by making you limp and holding it stiffly. And then that's a sort of a vicious feedback, a vicious cycle. So the stiffer it gets, the less the muscles work, and the less the muscles work, the more stiff it gets. So it just gets worse and worse. So anything that people can do to try and strengthen the muscles around a joint, the easiest thing, if people can, is just walk, to get out and just have a little bit of a walk every day. Don't push it, just find something that you can do without too much difficulty. Potentially try and just increase that a little bit, week on week, just to sort of push those muscles a little bit. can be helpful for people. We know that people can improve significantly with hip and knee pain just with reasonably straightforward exercising to try and strengthen the muscles. And it's not just about sort of strengthening the muscles, but the coordination. So the act of walking requires obviously balance on each leg in turn, and so the coordination of muscles around the joint is also really important. And then kind of moving on from more straightforward, just walking, it is sort of simple range of movement exercises to try and preserve the range of movement. It's unlikely you're going to be able to increase the range of movement in a arthritic joint, but at least we can preserve what's there. And then sort of moving on to more sort of floor-based exercises or Pilates type exercises that the patient's physios may have directed them to do either via leaflet or on Zoom physio groups or at the joint school or whatever it is, whatever system, really anything that you can do to sort of preserve movement and maximize the muscle function around the joint, I think will be really helpful for people.
Yeah.
I think the issue about sort of the double hip replacement or the bilateral hip replacement patient or someone with problems on both sides is that often we obviously see people quite frequently with both hips where there's pain on both sides. It's quite infrequent that we would do both at the same time, much more frequently to do one than the other one. And I think that question, I saw the question that came through there from the patient who I think they'd said that they were has been listed for one hip replacement, but also had some problems on the other side. But now it's been cancelled. The other one's getting worse as well.
Yeah.
Should they then have both done? Well, I obviously can't give specific advice, but what we do find is that after the first side, shall we say, patients, obviously their function can get a lot better because the bad side is really holding them back. And then you do the hip, and they get going a lot better, and actually then the increased exercise that the other hip gets actually allows things to improve. And they have a good leg, so whereas before they were really limping off the bad side onto the good side, but that was making it worse. So then when they can walk normally on the new side, it actually then offloads a lot of pressure on the other side, and then it's not as bad. So oftentimes we would say that if there's, unless there's a specific reason for doing both, let's just do one and see how things go. The corollary of that is that some patients don't seem to follow that pattern, and some patients seem to, you do one side, and then that's switched off the pain from that side, and now suddenly they can hear the pain from the other hip.
Okay.
And then in combination with their increased exercise, then the other one gets worse. So we seem to have two groups of patients, one where the other side, just goes into the background and doesn't bother them for a long time, and the other one where it's, oh my God, now I need the other one doing, or I didn't realize quite how good this was going to be, so can I please have the other one done?
Oh, fascinating. Yeah.
It's interesting, the response.
Yeah, it makes sense. And not on either side. And on a related question also about the delay, quite a specific one. So it's difficult to give an individualized and clear answer on it. But if someone who's wondering on behalf of their son, so this would be a pediatric case, so someone who's waiting for a hip replacement at quite a young age, and they describe the situation as having a collapsed hip. And are concerned about the long-term effects of a delay, of not having the operation for, say, 6 or 9 months, or perhaps a bit longer.
I mean, it's difficult to comment really on, as you say, on specific cases. I mean, it depends what the collapse is, so it's hard to say really. But I think that the advice that we already sort of talked about really is still pertinent really, in terms of trying to maximize muscular strength around the joint, and trying to keep mobile as possible, and whilst that's still possible. No, absolutely. And then, so if we move on to after surgery, so for those who have had the surgery now and are also facing the challenges with COVID-19 of not being able to
have as easy access to face-to-face appointments and post-op physiotherapy and rehab and so on. So there's a number of questions and a number of uncertainties, I guess, also for people in the post-operative phase, and the many different stages within that. But I think also around that, there's also a lot of things that could be beneficial and a lot of questions that would be relevant for people who are still sort of planning ahead and thinking about it. And particularly for younger people, a lot of this is about, and again, it does get quite specific, and as with everything, there's a wide spectrum, but there's many questions about, will I be able to get back to X activity after surgery? Will I be able to increase my level of activity after surgery? And are there, and I guess the most common question within this is, are there any activities that are absolutely, not allowed, so to speak, after a hip replacement? And how does that relate to trying to make sure that I'm doing all I can to enjoy life, but also maximize the lifespan of my new hip?
Yeah, so it's interesting. I think a lot of the sort of advice from the likes of me and surgeons over the years has changed. It used to be, you can't go swimming, you can't do breaststroke, you can't run, you can't go skiing, and all these things. I think over time, I think the surgical community has realized that the patients actually do what they want, unsurprisingly. And I think we're now catching up with what patients are doing. And at the annual meeting of the British Hip Society, I think it was last year, there was a session on, what do you allow your patients to do, whatever that means, and it was really quite telling, actually, that the vast majority of people, surgeons, didn't really try and place any realistic restrictions on people once they've got over the recovery period, obviously. So I think now we're much more relaxed about what people do afterwards. Again, you will find again that difference of opinion in people, in surgeons. Generally, my approach is if you're doing something before, then it's probably realistic to get back to be doing that afterwards. So and generally, so I suppose in terms of what activities would I really not encourage people to do, I think sometimes I do tend to suggest people avoid doing really deep squats with heavy weights, because that does place a real rotational force on the joint replacement, which is probably it's one of its weakest links, I suppose. But fell walking, climbing, running, cycling, triathlon. I've had people that have done Ironmans. The internet is littered with videos of people. I'm a black belt, in karate after my hip replacement, dancing, all these things. You'll find, there are people that have done almost everything, climbed Everest, and all these things. So I think it's a matter of, I always tell people that the really important phase is the first, sort of within the first 3 months after surgery. So for example, if you've used uncemented implants where the bones have to grow into the implant, then that process occurs within the first 3 months. After that, it's not going to happen anymore. So if you don't want to overload the joint in that period, you want to allow it to heal. It's a bit like a fracture. You want the bones to heal, and once that's happened, then you can then start to sort of work up through activities. So I think that the two important points are to really not push things at all in that first 3 months. When you do start going back to activities, to gradually build it up, because you will have had a long period of not doing anything really. The period before the operation where it was too painful and the muscles became weak, and then you've had 3 months of not doing a lot, and then to start activities again then. So people shouldn't go back into the level that they kind of want to get at.
No.
Start really slowly and gradually build up the muscle strength. And that I think for people who want to be really active, that's the time where they really want to be engaging with a physiotherapist. So the physio can really assess, the symmetry of their muscles, the coordination, and their balance. It's not as much about strength. It's about, will the muscles protect the joint? Because that's what they're doing. So it's about those coordination tests and things like that, and balance and core strength and stability.
Yeah, absolutely. And of course, we're worth flagging again that there will be people out there who are given quite specific precautions and a plan. And of course, that, if you're given a plan, as ever, if you're given a plan from your surgeon or from your physiotherapist, that's the plan to stick to.
Yeah, absolutely.
Related to that, though, and that may well be within some of these precautions that people are given, but a common question is sort of around certain movements, but in particular crossing the legs after a hip replacement. And that's something that we've seen pop up quite a lot as a question, like will I be allowed to / will I be able to cross my legs after surgery?
Yeah, so a lot of places will use what we call hip precautions for a period after surgery, which might involve things like not crossing your legs, not bending the hip more than 90 degrees, lying on your back in bed, using a raised toilet seat. So a lot of these are historical. They've come from the past, and many units are stopping using such precautions, but some units still do. So the important thing, as you say, is to follow the advice of your unit and your surgeon, your clinical team. But generally, once the hip precautions period has elapsed, then generally it's a case of, if the hip is comfortable in a position, then it's safe. And yes, some surgeons would still say don't cross your legs and don't do this and don't do that and do the other. But personally, for me, I tell patients that that's fine. They can cross the legs if it doesn't feel like it's pulling the joint. I tend to advise people, it's the bending forwards, really deep flexion, which is sort of one of the riskier activities. So I generally tell people when they're trying to reach their shoes and socks, or clean their feet or whatever, to sort of reach down with the hands between the knees rather than around the outside of the leg, because that reaching around the outside with flexion tends to sort of put the hip a little bit at risk. But again, it's listening to your own body, and if it feels pretty safe and it's not stretching, then it probably is quite safe.
And I guess with another common question within the sort of the earlier stage, so while one might be on precautions and things like that, and often as part of a rehab protocol there will be a pain management plan with that, and of course that's something that is also deeply personalized and has to be very specific. But by and large, the one question that we've had sent in by a few different people in various forums is like, how long can I expect to be taking, I currently take painkillers off and on for my hip. How long can I expect to be taking painkillers after hip replacement? What's the sort of the average around that?
Yeah, so
difficult,
you're absolutely right that it's very, very patient specific. So it does massively depend on what someone was taking beforehand. If they're on high doses of opiate-based painkillers, or morphine and tramadol and things like that, then obviously it's going to take a little longer to get off things. But I'd say, if an average patient who is perhaps taking, some anti-inflammatories, paracetamol, maybe a bit of cocodamol, now and again, the vast majority of patients come back. If we see patients at 6 weeks, I'd say most people say, well, I stopped taking painkillers 2 weeks afterwards, 3 weeks afterwards, that sort of thing. So by 6 weeks, most people are not taking any painkillers. Obviously, that's.
And of course, just to flag that if someone is currently, who's watching this is beyond that stage after surgery and still finding that they're needing painkillers, then that's not, it's very much a case.
That doesn't necessarily signal that there's a problem with the joint or anything like that. Yeah, no, absolutely.
Well, I think we've covered quite a lot. I mean, it is difficult because these are such personal conversations and a lot of personal decisions and shared decisions for each individual to make together with their surgeon. But I think we've done a very good job. It's been wonderful speaking with you and going again, sort of dipping into your experience and some really interesting and fascinating points about what you're finding from how patients are responding to this procedure, which is I think I've heard it quoted many times as one of the most successful operations in orthopedics, maybe of all surgery, in terms of the number of people and the improvement it can have to quality of life. So that's worth remembering as well, that it really is something that helps a lot of people, and it's been around for quite some time.
Yeah, absolutely. I mean, obviously, where I work at Wrightington Hospital, that's where Sir John Charnley sort of developed the modern hip replacement. So, in about 1962 was the first sort of iteration of the really successful joint replacement. So lots of sort of innovation since then. And yeah, you rightly say that it is, in terms of quality of life improvement, it's really up there. Probably number one and number two of operations to improve patients' quality of life. And that's obviously why, as a surgeon, we like doing it, because it's so nice to see patients coming back to clinic, that are really, happy. And it's worked really well. But in addition to that, it's also really important to understand that, it's not 100% successful, and some patients do have problems. There is a risk of complications, and that again will be discussed by the surgeon with you in terms of consenting process. Infections, dislocations, fractures, nerve problems all do occur sometimes, and we see plenty of people every year that have had problems from it, and many of those you can treat and it gets better, but some won't be. And again, therein lies the rub about when to have the surgery. It's like, well, yeah, if it's not too bad, I'll wait, because what happens if I had a complication? I'd really regret having had it at this time. That was maybe something we could have talked about before, actually, but that always does come up, that you have to have that conversation about what if it doesn't go well.
But perhaps that's something worth doing a full separate session on.
Yeah, I think that's probably true, actually. I think, and that would be a really useful resource for people, I think, to look back on, in-depth discussion about actually what an individual complication might look like for a patient, and how that might affect their life. That'd be useful.
Yeah, absolutely. Well, thank you so much, Prof. Ward. It's been really fantastic. Dipping into your knowledge and experience. Is there anything else you'd like to add before we sort of?
Probably just to talk about when surgeries might restart. It is elective joint replacements have restarted in some hospitals in the UK already. Obviously, that's due to the differences in the in viral infection rates in different parts of the country. When areas where there hasn't been so much, they have done some restarting. But I think everywhere at the moment every hospital is making plans to restart and how that might look. So although patients may well be sitting at home saying, I've not heard anything from the hospital, I had a letter months ago which said it was going to be a few months and I've not heard anything, don't worry that every hospital will still have you on the list, and we'll be making significant plans. There's constant Zoom calls about what it's going to look like and how do we do this. So it is in the planning stages. So we will be restarting at some point. So we will get to everybody.
Yeah, no, absolutely. I mean, I'm certainly getting that impression from speaking with people such as yourselves in different hospitals. There is a lot of people out there working very, very hard to enable a return to surgery as soon as it can be done in a safe way. As soon as it can be safely done. As you rightly say, that will vary, and but watch this space. Where as we hear how things develop, we'll be posting about it through Joint School and things like that. And of course, if you have been booked in, your clinical team, your surgeon, they will be in touch as soon as they know to look at booking people back in and start making more specific plans for the coming months. Super. Well, and I think that's been a really useful session, and I think we've flagged and highlighted the need for another one. So watch this space. We will be back. And in the meantime, everyone out there, thank you so much for the questions you've sent in. Please do keep them coming, and any feedback on these, on what we've covered today. Was there anything that we missed, or anything else that you'd like us to dig into in a separate session? And as ever, keep up the good work, and be well and stay safe out there. And we'll see you next week. Bye bye now.